Okay, let's dive right into this explainer. We've designed this specifically for MRCOG candidates who need to absolutely master the RCOG and BSUG Green-top Guideline number 46 on post-hysterectomy vaginal vault prolapse. If you're prepping for exams or honestly just looking to solidify your clinical governance and surgical knowledge, you are in exactly the right place. We're going to break down this complex clinical pathway into structured, highly testable concepts.
So here's our primary source today. Published in July 2015, this replaced the older 2007 edition, and it's basically the strict, evidence-based roadmap you'll need for both your written papers and your OSCEs. It's absolutely packed with specific gradings of evidence, which, as you know, examiners just love to test.
To make this super efficient, we're covering 6 main areas: diagnosis and clinical assessment, prevention strategies, conservative management options, surgical treatment options, concomitant SUI and recurrence, and finally, clinical governance. Let's get to it. Right, Section 1, Diagnosis and Clinical Assessment. As we look at how to initially evaluate a patient, keep in mind that using standard classification systems like the ICS POP-Q is absolutely mandatory. You've got to have that objective documentation.
Now, you might be wondering about urodynamics, and this slide hits on a classic exam trap. You will almost certainly see a scenario where a woman is currently continent but scheduled for prolapse surgery. So, do you test her?
The short answer, no. Routine urodynamic assessment is explicitly not recommended. This is a grade B recommendation. Why? Well, studies like the CARE trial actually showed that trying to predict occult stress incontinence with preoperative urodynamics just isn't always accurate, and if you treat it prophylactically, it often leads to unnecessary interventions. So clinical assessment remains your absolute best tool here. Oh, and remember, these patients really should be assessed within a pelvic floor multidisciplinary team, or MDT.
Moving on to Section 2. Prevention strategies. Let's look at the surgical techniques we can deploy right at the time of a hysterectomy to stop vault prolapse before it even becomes a problem. Examiners really want to know if you can actively prevent this condition. For the MRCOG, you've got to memorize these specific, high-yield preventive techniques. First up, performing a McCall coldoplasty during a vaginal hysterectomy has strong grade B evidence for preventing subsequent prolapse. Suturing the cardinal and uterosacral ligaments to the vaginal cuff, also grade B evidence, and that applies to both abdominal and vaginal hysterectomies. Finally, if you're closing up and notice the vault descending all the way down to the introitus, you should consider a prophylactic sacrospinous fixation, or SSF. That one is a grade C recommendation.
But knowing what not to do is just as important. Subtotal hysterectomies is explicitly not recommended for preventing post-hysterectomy vault prolapse. That's backed by grade A evidence, so lock that in. Also, if you're thinking about using permanent sutures for vault support, don't. The guideline clearly states there's inadequate evidence for short-term use, zero long-term benefit, and a really high risk of suture exposure. Okay, Section 3, Conservative Management Options. Before you even think about jumping straight to surgery in a management plan, you must demonstrate to the examiners a firm grasp of non-surgical options. And these are strictly based on the objective POP-Q stage.
It's a pretty clear dividing line. Pelvic floor muscle training is your go-to grade B treatment for women with stage 1 to stage 2 prolapse. But once that prolapse is more advanced, we're talking stage 3 through stage 4, vaginal pessaries become your primary alternative conservative option. Which brings us to Section 4, surgical treatment options. This is the absolute core of the guideline. The golden rule you need to remember: surgery must always be tailored to the individual patient and performed by an appropriately trained specialist. No exceptions.
Get ready for the surgical showdown. We're looking at a direct side-by-side comparison of the 2 highly testable, effective treatments for primary vault prolapse. On one side, open abdominal sacrocolpopexy, or ASC. On the other, vaginal sacrospinous fixation, or SSF. You absolutely must know these grade A distinctions for the exam. ASS wins out on 3 massive fronts: significantly lower recurrence, lower rates of dyspareunia, and lower postoperative stress urinary incontinence. But SSF is no slouch. It clearly offers a much faster recovery time, plus it's a shorter and less expensive operation. Just keep in mind the caveats. SSF might not be appropriate if the patient has a short vaginal length, and it definitely requires careful thought if they already suffer from pre-existing dyspareunia. For the written papers, remember that laparoscopic sacrocolpopexy, or LSC, is considered just as effective as the open abdominal approach, earning it a solid grade B recommendation.
Robotic sacrocolpopexy, however, has limited evidence and should strictly remain in the realm of research or prospective audit. That same research-only boundary applies to high uterosacral ligament suspension, or HUSLS, as a first-line treatment. And here's a massive safety point for HUSLS. Examiners want to make sure you know there is a significant risk of ureteric injury, especially when it's done laparoscopically.
Now we hit a highly scrutinized surgical topic. When it comes to mesh, you must stick exactly to the 2015 evidence updates.
Here is the crucial takeaway. Transvaginal mesh, or TVM, is absolutely not a first-line treatment. The evidence simply does not support it. If you're even considering it, it mandates a full MDT discussion. On top of that, the patient has to be extensively counseled on the permanent nature of the mesh and the risk of really serious, tough-to-treat complications.
On the completely opposite end of the surgical spectrum, we have colpoclesis. This involves the surgical closure of the vagina. It's a highly testable, short-duration, low-complication option with a grade C recommendation. Remember the specific patient profile here. It's tailored specifically for frail patients or those who definitively do not wish to retain sexual function. All right, Section 5, concomitant SUI and recurrence. This is a scenario that trips up a lot of candidates. How do you handle a patient presenting with vault prolapse alongside stress urinary incontinence or dealing with a recurrent prolapse?
The trick is differentiating occult from overt SUI. If a woman is previously continent, meaning she has occult SUI, performing a colposuspension at the time of an ASC is an effective, grade B recommended way to reduce postoperative SUI. But, and this is a huge but, if she has overt pre-existing SUI, doing a colposuspension during an ASC just doesn't appear to be effective. For overt SUI, you might consider concomitant mid-urethral sling surgery, but typically when vaginal surgical approaches are used.
If an exam question throws a recurrent vault prolapse at you, whatever you do, don't try to be a hero in your answer. Your immediate reflex has to be referral to a specialist pelvic floor multidisciplinary team. The guideline is incredibly clear that managing recurrence takes specialized experience and training.
Finally, Section 6, clinical governance. This is an essential pillar of the modern MRCOG exam. It goes way beyond just knowing your clinical surgery. They want proof that you are a safe, accountable practitioner. To nail those top marks, you've got to list these exact governance requirements. Number 1, all surgical outcomes and complications must be documented in a national database like the BSUG surgical database. Number 2, you have to use standard IUGA and ICS terminology to classify any graft-related complications. And number 3, it is legally mandatory to report all complications related to devices and mesh directly to the MHRA.
Well, we've covered a tremendous amount of ground today, haven't we? From skipping unnecessary aerodynamics to knowing exactly when to choose ASF versus SSF. As you head into your exams, and more importantly, your clinical practice, ask yourself, how are you going to apply these strict evidence-based recommendations to guarantee the highest standard of surgical care? Keep this framework in your head, trust the guidelines, and you are going to be incredibly well prepared. Good luck.